Good afternoon. My name is Stefano Crinò, and I work at the Pancreas Institute of Verona in Italy. Today, I'm going to talk about a wonderful device which improved our accuracy for the diagnosis of pancreatic cystic lesion. It is a microforceps able to pass through a 19-gauge needle and able to collect a piece of tissue from the cystic wall. Its name is MORAY Micro Forceps. And in particular, I'm going to focus on these 4 points. So which cyst I should buy with MORAY Micro Forceps, some technical tips and tricks, how many specimens should be retrieved, and how to handle acquired tissue. As you all know, pancreatic cysts are often incidentally discovered in a healthy population with a mean prevalence of 12%, and this prevalence increases with age. So the diagnosis, a precise diagnosis, is really important because we are dealing with a lot of diagnosis. And from a pathological point of view, pancreatic cystic lesions could be classified in epithelial neoplastic or epithelial non-neoplastic, or non-epithelial neoplastic and non-epithelial non-neoplastic. But from a clinical point of view, we should differentiate IPMN from other unknown cysts. And the reason for this differentiation is that IPMN are usually managed according to clinical and radiological features, such as the presence of solid mass, the presence of jaundice, enhancing mural nodules, or dilation of the main pancreatic duct, and so on. Rather than finding on cytology. Differently, other cysts are usually managed according to the histotype of the cyst. On the other hand, other unknown cysts usually are resected based on presumed diagnosis. But as you can see in this study, there is a not negligible percentage of misdiagnosed cystic neoplasm, and a lot of neoplasm resected were even non-neoplastic in this study. So the authors concluded that clinical and radiologic diagnosis of pancreatic cystic neoplasms is often inaccurate. And similar results have been reported in this study, where a relevant number of patients underwent pancreatic resections for benign cysts, with a rate of incorrect preoperative diagnosis of about 30%. And the typical example is the unilocular pancreatic cyst in the tail that is resected with presumed preoperative diagnosis of mucinous cystic neoplasm. But as you can see in this image, only one was a mucinous cystic neoplasm, whereas the others are completely different histotypes with completely different management. So we must be aware of the information that we can have from different specimens we can collect when we puncture a cyst. The cyst fluid can give us information about the whole cyst. So we can find dispersed cells, we can perform biochemical analysis or molecular analysis. But with a MORAY Micro Forceps, we can obtain a piece of the cystic wall, including epithelium and stroma, so we can define exactly the cyst histotype by performing immunohistochemical analysis. So when to use the MORAY Micro Forceps? When the question is, which is the cyst histotype? And the knowledge of the histotypes change patient management, because we know that with the MORAY Micro Forceps, with a through the needle biopsy, and this is the name of this procedure, we can obtain a diagnosis, a precise diagnosis, a specific cyst diagnosis in about 78 or 69% of cases, that is absolutely higher than cytology. But for IPMN, if we already know that that cyst is an IPMN, for example, if we clearly see a communication with the pancreatic ducts, we should ask ourselves, are worsening features present? And the target, so the nodule perhaps, is reachable with the microforceps? And more important, does patient management change according to the grade of dysplasia? About clinical data, I would like to show you two meta-analyses. In the first one, including 11 studies with 490 patients, the adequacy was 85% compared to FNA with an odds ratio of 4.8, sorry. The diagnostic accuracy was 78%, that was significantly higher compared to FNA. And there were 20 mild bleeding and 2% of mild pancreatitis. In this other meta-analysis, the technical success was 98.5%, the diagnostic yield about 70%, and a correspondence with surgical pathology was observed in 93%. So what we found with through the needle biopsy is reliable. But we had also observed a little higher rate of adverse events, including intracystic bleeding that are almost always indolent, but also a little higher risk of acute pancreatitis. And I also would like to spend a few words about this study, a prospective study recently published in Endoscopy, including 101 patients, with primary outcome was change management of pancreatic cystic lesion following through the needle biopsy. And as you can see, through the needle biopsy led to a change in clinical management only in 11.9% of cases, with 3 severe and 1 fatal adverse events. So looking at the results, you can say that through the needle biopsy is not useful, or is useful only in a few percentage of cases with a not negligible risk of adverse events. But if you look at the population included in the study, you can see that the majority of patients were IPMN that are usually managed according to morphology, as I said before, rather than histology. So it is likely that through the needle biopsy didn't change management for this reason. Moreover, worrisome features were present only in 60% of cases. And all adverse events occurred in IPMN. In particular, the fatal event was in an 85-year-old man, so is a really old man with a mixed type IPMN that probably shouldn't underwent through the needle biopsy. So patient selection is crucial. About tips and tricks, first of all, you must choose your target. Before using the microforceps, you should aspirate some fluid for 2 reasons. First, reduce the cyst tension, and second, obtain some clean fluid for analysis. In these cases, we decided to sample this thicket septa here. You must push gently the microforceps on the cystic wall and close the valves really slowly. And sometimes, if you catch a big amount of tissue, you should strongly pull back the MORAY But don't forget to hold firm the needle handle to avoid dislodgement of the needle outside cyst, as you can see in this video. Finally, you can use your needle as a standard needle. You can perform biopsy as we did here to collect even more tissue if necessary, and don't forget to empty the cyst. We can reduce or try to reduce the risk of adverse events. Yes, of course. First of all, we should perform prophylaxis with indomethacin or diclofenac, as we usually do for ERCP. We should reduce the number of bites or specimens to be collected. So in other words, we should reduce the trauma on the cystic wall. We should reduce the time of the procedure, the time we spend with the needle inside the cyst, and of course, we must aspirate the cyst at the end of the procedure. And we investigated how many specimens should be retrieved in this paper, and we found that at least 2 specimens are necessary to significantly improve the outcome compared with cytology. In particularly, we evaluated the possibility to differentiate mucinous versus non-mucinous cysts, the possibility to obtain the epithelium, the possibility to define the grade of dysplasia, and the possibility to define a specific diagnosis. And we found that the third specimens didn't improve any of these outcomes. Another important point is how to handle the specimen. First of all, you should discuss and collaborate with your pathologist. And we put the specimen between 2 paper discs, colored paper discs, that allow us to find the specimen in the paraffin block. And another important point, you should put only one piece of tissue in a jar, in a paraffin block, because if you look at this picture, you can see that if you have several pieces of tissue in a paraffin block, when you cut the paraffin block, you are going to waste a lot of tissue. Differently, if you have only one piece of tissue, you are going to obtain several slides and you are going to optimize your specimen. And I would like to share this elegant paper with you, where a nice flowchart is presented that guide you along this path, where different diagnoses can be done according to the presence of epithelium and stroma, epithelium, only stroma without epithelium, or only epithelium without stroma. And several immunohistochemical analyses are suggested to reach the diagnosis. And I would like also to highlight some limitations related to the nature of the lesions that we are going to sample. For example, in this image, you can see that almost all the cystic wall has a low grade of dysplasia, but in this point, there is a higher grade of dysplasia. So if you sample the cyst here, you are going to underestimate the grade of dysplasia. Or in this case, you have a large portion of the cystic wall that is just a fibrous tissue. So if you sample the cystic here, you are going to make a misdiagnosis. Differently, if you sample the cyst here, you are going to do an excellent diagnosis. And unfortunately, it is impossible on US examination to differentiate these portions of the cystic wall. So in conclusion, through the needle biopsy is feasible in almost all cases. The MORAY Micro Forceps is the only available tool able to retrieve a piece of tissue useful for the definition of the cyst histotype, diagnostic accuracy is significantly higher than cystic fluid cytology, but a higher risk of adverse events is reported. So patient selection is crucial to optimize the clinical impact of this procedure, and a careful specimens handling and cooperation with pathologists are essential for success. Thank you very much for your attention.